Liza Greenberg with the Patient-Centered Primary Care Collaborative. We're just waiting for a few more people to join and then we'll get started. I just wanted to let you know that the session is being recorded. Okay, well, why don't we go ahead and get started. Welcome, everyone. We're so glad you could be on. I'm Liza Greenberg. I'm the project director with the Patient-Centered Primary Care Collaborative Support and Alignment Network. And we are here today as part of a pediatric learning network adopting person and family engagement strategies to improve pediatric asthma care. Today on the call, we'll have our subject matter expert and quality improvement coach, Ruth Gabernick. We have a practice innovator, Rashana Ali, and Ruth will introduce herself and Rashana shortly, and I'll be facilitating the call today. What we're here to do is to identify strategies for improving asthma care in pediatric practices with the goal of reducing emergency utilization and potentially hospital admissions. Today specifically, we'll be talking about the TCPI, or Transforming Clinical Practice Initiative, Person and Family Engagement Structure, highlighting an innovative pediatric practice that uses person and family engagement strategies, talk about some of the facets of person and family engagement, including patient activation, health literacy, medication management, and shared decision making. So together those techniques and tactics help to improve asthma adherence and asthma outcomes and are part of a quality improvement program. We'll talk about reasons and ways to identify practice populations and then share resources at the end of the call on how you can go about identifying strategies that work in your own practice. So this is the 5-part series of calls, and for many of you, hopefully many of you, it's the second call. In May, we talked about the CMS TCPI concept of engaging patient and family voices in care. Today, we'll be talking about the 4 metrics that I just mentioned: shared decision-making, patient activation, literacy, and collaboration. And we'll be doing that for a couple of calls because it is a major concept in quality improvement. These are the person and family engagement metrics identified by the Transforming Clinical Practice Initiative, and just wanted to show them briefly because they do fit together as ways to really pull in the voice of the patient and family in how to structure a quality improvement program, and then takes it down to the level of the patient and family interaction with a clinician to really maximize the value of interventions and hopefully improve asthma outcomes. And we wanted to kind of show that as a graphic as well, and some of you saw this graphic in our last call, but this is the National Heart, Lung, and Blood Institute Asthma Care Reference Guide. It shows the algorithm for diagnosing and treating asthma, and basically you don't need to do something different in your clinical protocols, but you layer on strategies around person and family engagement to improve the outcomes and to also improve practice flow, retention, visit adherence. So in addition to helping with the overall patient clinical outcomes, it helps make your office work more effectively when patients can be engaged as partners in the care process. So why don't I stop for a moment and show our first poll, looking at how do you all know how you're doing in terms of patient care management and patient outcomes. And Jacinta, can you put up the first polling question? And each of you should be able to click on your screen to answer the questions about the data you have available in your practices. Let's see. Jacinta, do you know how to open that up? And for those of you who access these slides later on our website, we do ask that you complete our follow-up survey that asks you what you've been doing and what you intend to do around asthma quality improvement over the next few months that we participate in this learning network. So I see that the poll is up you have multiple choice questions, and we'd like to find out about the data you have available. And then, Jacinta, can you put up the results, and we'll take a look at what people are saying? Let's see. And I cannot actually see the results, so we're going to move on, and we'll get those for you and show them to you at the end.
I can see, Liza, this is Ruth. I can see the percentages. Yep.
Oh, great. Can you tell us what you see?
Okay, sure. I can see that asthma medication prescribing, that 25% said that they most often that's available to practices. Asthma medication adherence through refills or another method was also available for 25% of the practices. Asthma-related emergency care, 50% of the practices have access to that information, as reported by the coaches. Pediatric asthma registry, 75% of the practices have that, which is great. And we get data reports from health plans, hospitals, or a practice transformation network, and 50% said that that's how they get their data.
Great. Thanks for reading those off. And you know, one of the key takeaways from our first call was how important it is to be able to identify the patients in your practices through a registry or some other means. So it sounds like people are pretty far along on that, but there are some gaps in data that help you understand both who your patients are with asthma and some of the follow-up principles, you know, for example, medication adherence and medication refill patterns. So Ruth, that's something that we can work into our discussion throughout the rest of this call. And I wonder if we can do our second poll, Jacinta, on the actions taken by members of the audience about follow-up from our last call. And as you may recall, we had asked if you could talk to some of the patients in your practices about what it is that would help them be more adherent with asthma protocols, to understand what their care management activities are going to be, and then hopefully that would translate into staying out of the ER. So interested to know if any of you were able to take any action to start planning within your own practice for asthma quality improvement. So we'll give it just one more minute, and then Ruth, I'll ask you again if you can read off the results. Okay. Ruth, you want to tell us what people are saying?
Sure. I'm pleased to tell you that 0% said that there was no activity since our last call, so that's awesome. 67% said they reviewed data on quality improvement opportunities. Another 67% said that they met with other staff and project teams to develop a QI approach, and 67% met with a patient to discuss ideas for improving asthma. And 33% reported that they developed an action plan for QI, including patient and family engagement. Great, great work.
Yeah, thank you so much for telling us what you've been working on this past month, and we're going to continue on through the presentation. Ruth, I'm actually going to hand it off to you from now on.
Okay, all right, thanks, Liza. Good afternoon, everybody. This is Ruth Gubernick. It's my privilege to get to spend some time with you again this month, and just wanted to refresh everybody's memory. Just this is the definition of patient and family engagement that has been publicized, especially through ARC, and is well received. And just talking about that patients and families need to be actively engaged at all levels of healthcare, including pediatric primary care, and that there's a need to ensure free flow of information to and from the patient and family, and an environment where those patients and families are always treated with respect. So on the next slide, I have a privilege this afternoon to introduce to all of you a an individual that, a professional that I met. I had the privilege of meeting last week at the New Jersey Population Health Summit, and to hear about some of the great work that she and her team at her organization have been working on. Roshana Ali is a licensed practical nurse, and she's been serving as the asthma educator for the Wealth from Health program that is going on at Jersey City Medical Center, which is part of the Robert Wood Johnson Barnabas Health Program health system in Jersey City, New Jersey. Roshana, I'd like to turn it over to you to share with everybody some of the great work that you've all been doing.
Okay, thank you. Can you guys hear me? Good afternoon,
yes,
everyone. Okay, thank you for having me out. I am an asthma educator with Jersey City Medical, and what I do there, we have a program that is an innovative self-management program which provides the opportunity of rewards to patients in the Hudson County area who are diagnosed with one or more chronic diseases, but that are also sensitive to coordinated outpatient and acute care. We find out patients either through inpatient access, whether they're in the ED or they're admitted to our unit. Or we also have partnerships throughout the community where we go into pediatric offices, school nurse association, religious practices, as well as just community vendors as well. We do a lot of tabling, health fairs, and that's where we meet our patients. And what we do with these patients is once we meet them is we try to make sure that they have their asthma treatment plans in place, that they are following up with their physicians, that they have their asthma action plan in place and medications given into school and also are being prescribed through the pharmacy. Through this program, we deal with asthmatic patients, but also a number of chronic diseases. So we deal with the patient and family as a whole.
Next slide.
Next slide. Yes, next slide. So here on this slide, it kind of just shows what I was telling you as far as our ED, our pediatric inpatient, a lot of the things that we do with the families. We have initial house calls, so we do go into the home and we do environmental house calls for the patient, where we go in and we check the humidity levels. We're checking this to make sure that they have medications in the homes, that they don't have anything in the home that is triggering the child on a daily basis. We do medication reconciliation with them. We also make sure that all paperwork and things are done and into the school nurses. We do EMI videos, which are educational sessions that are prescribed through email for the families on their chronic condition, whether it's asthma, peak flow meter, medication, nebulizer use. We also do a lot of subspecialty and PCP referrals. So if we come in contact with a family who does not have a primary care physician or does not have a specialty pulmonologist, we will connect them with one in our community, as well as go with them to the appointment so that they understand the medication and they understand what is given to them, provided to them through their physician. We also do a lot of monthly support groups. So on Saturday mornings, 11 to 1, one Saturday a month, we have a support group that we do for our families in the community, where we're teaching them about asthma, where we're teaching them CPR and first aid, where we're teaching them medication reconciliation. We're doing fun educational activities for the families so that they are learning about asthma and why they need to do and take the steps that they're taking to live healthy. We also have essay competition in the community that we do once a year, where this is given out to all of the schools, K through 12 in Hudson County. They have 3 topics on asthma that they can write about, or either do an essay board, a poster board, and this is our 3rd year that we have done the competition in Hudson County. We provide a lot of resources for our members in the community. We provide mattress covers, pillowcase covers, allergen sprays, peak flow meters, spacers. So all of these things are provided to our members free of cost, as well as also doing cooking matter tours which are nutritional educational tours so that they're learning to eat for their allergy type or learning to eat for their food type or their chronic disease that they're suffering from. We have all of our support groups are bilingual, so Spanish and English. And we also work with the Lung Association of America to do open airway programs inside Hudson County schools. So we're also working with the Hudson County schools so that we can make their schools asthma friendly, making sure they have no idling signs in front of the schools, that all schools have nebulizers, and that they're also trigger free to help each student in their school system. Next slide. Okay, and then here on this slide,
Roshana, this is Ruth. If I could, I have a few questions. I think that was the last slide for your presentation, the previous slide. So if we could go just, back to that in case anybody wants to continue to look at that. I wondered if you could share with the group how you recruit for your participants for the support group. How do you find out about them, and how do you get them involved?
Okay. So through our health fairs in the community, this is how we recruit community members. Anyone who touches our ED who has a diagnosis of asthma exacerbation, shortness of breath, wheezing, will get a red flag. So we're able to come out and touch those families and invite them out to our support group. So most of our recruitments come from either in-house or in a community organization, such as a health fair in the community where we're signing up patients. We tell them about the services that we have, and then they're invited out. We either will call them, we will send out invites, and then just with the general calendar that we send out monthly that has all of our support groups, we try to make sure that each month our members get that calendar so that they have access to the support groups that are being offered for that month.
Great. I love that you said that you have fun activities too. So yeah, it really
we try to plug that in because a lot of parents, yes, do not want to come in on a Saturday to hear more lectures and things like that. So we try to do like Lungo, where it's lung bingo, so the kids are having fun. We did talking lungs. We made mucus. We had our ENTs come in and do CPR and first aid with the kids so that they were able to get on the rig and they were able to, get why they call 911 and when to call 911. So we try to make it fun so that they will come back.
Great. That's great. If we could open the lines in case other folks have some questions for Roshana. And then if you could mute your own lines so that we don't have the background noise, that would be greatly appreciated. But please don't put us on hold. Okay.
We've also opened a chat box for anyone who would like to chat in a question.
Great. Thank you. Any questions or comments, or anybody want to share a similar program that they may, or some elements of this program that they may be doing in their own community, or partners that you've connected with for home visits or with the schools? Or
painkillers, they take the medicine out of a
if you could identify yourself and then just jump right in, that would be great.
Legit. So, but it's definitely.
A few people are still muted, but you can raise your hand by clicking the hand raising icon on your screen.
And I said, why? And he said, we just can't do that. We can have problems with this. Come on back. I want to show something to everybody. So I'm going to show what happened.
So we just heard something. We may need to remute everybody and then go on, and then people could chat in questions or suggestions. I think we're interested in hearing examples of organizations that have done similar programs or challenges you may have had. Ruth, you ready for the next slide?
Okay, if nobody's chatted in, I don't know if Lindsay's still on the phone. I know there were some practices she's worked with. All right. Well, If not, we still then, this is quality improvement work, and we have to continue to improve the quality to make sure that everybody can be heard. But don't forget the chat box. Okay, we'll move forward. Before we do, Roshana, I just want to say thank you so much for taking the time to share what you've done, and even some of the things that we don't, I was just thinking, gee, you didn't think about that. I mean, talking to the schools about no idling and things that can impact kids and families with that, people with asthma, and your connection with the Lung Association and other, the home visiting folks in your community. So great job. Oh, and also the educational videos that you're emailing out to individuals. That sounds like if there's some in particular that you find are really well received, if you could share those with us, that would be terrific.
Sure, I will definitely talk to my supervisor about that, and thank you guys for having me on. Thank
you. Okay. So we'd like to continue. I don't see anything in the chat box. So one of the areas that we want to focus on today has to do with health literacy. And, patients come to us with various levels of education or literacy, and they may prefer to speak different languages, and these issues also often becomes barriers for them to understand health information. And really, it's the researchers that realized this was an issue and began to talk about health literacy, which is defined as having the capacity to obtain, process, and understand basic health information and services, and to make appropriate healthcare decisions and act on health information, and also the ability to access or navigate the healthcare system, which we all know can really be extremely complicated. Any patient who doesn't read or write well has trouble communicating or understanding verbal communications about health. And if they speak another language or have trouble understanding or using numbers, they could have more difficulty with the areas of understanding health information and making healthcare decisions. So on the next slide, I like this list. It gives us some of the red flags for low literacy. Just a few of these I wanted to point out because I'm sure you're familiar with them, but it's an opportunity to just kind of think about it again. And the fact that, often when patients or families are missing appointments, it could be due to the fact that they're unable to read the appointment slip, or it may mean that they don't have the organizational system at home to be able to remember that appointment. Even when you're making outreach and follow-up calls and other outreach or reminders. So it's an opportunity to really engage that family and see what are the reasons. Is it low literacy, or are there other reasons related to missed appointments? The fact that incomplete registration forms, that should serve as a flag that maybe the individual patient finds them too complicated, even though you feel that they've been.
You listen to a PowerPoint presentation?
I'm sorry, I can hear somebody, I'm not sure, but if you can mute your line. We know that many of you, I always hear about the frustration when patients and family members, when patients aren't given or don't receive their medications correctly. But that too can result because it's not because they don't want to do it right, but because they don't have a clear understanding of the importance of the medication, and they need to continue to take them until all of the pills or the bottle is empty, and how to refill may be an issue. So looking at this list and thinking about the patients and families that you serve, you probably know, which families may need some additional information, or maybe receiving it a different way in order for them to be able to be successful. and even, lack of follow-up for tests and referrals. That can be frustrating for clinicians, but also frustrating for the families because they're struggling with understanding how to do that follow-through. So we're going to talk about today some of the opportunities to improve that communication. The next slide, is this popping in individually? That's interesting. On my slide deck, I didn't have that as a add each one. So please, if you could complete that there. So this is the complete list of certainly not necessarily the only barriers, but ones that you certainly can recognize. Next slide, please. So, you can't always tell somebody's literacy level just by looking at them, or, people may present themselves well, they may speak well, and appear to understand what's going on, but that doesn't mean that they truly do. And the best approach for care to make sure that they're understanding things, are to use use simple language, making sure that the language used in the health field is simple, because normally, as we know, things that we take for granted as everyday language are often not understood, and families don't always understand what the diagnosis may mean or what's being asked of them. So everyone who normally manages health information even those who do may have increased difficulty under certain circumstances. They may be feeling anxious or overwhelmed. I know if a diagnosis that I'm concerned about is delivered to me, from myself, or to one of the members of my family that I'm with, that I may not hear anything beyond that point because I'm so focused on, on just what the diagnosis may mean. So at the end of the day, there are some good strategies and the use of simple, clear language to avoid any opportunity for misunderstanding, so that everybody can understand and benefit from what you're discussing with each other. On the next slide, here's a list of some key communication strategies. These are from the AHRQ Health Literacy Universal Precautions Toolkit, the second edition, which is, if you haven't discovered this yet, we've posted it on the website, on the webpage that Liza's created for this group. And both the first and the second editions, which are each a little different in the way they're formatted, have some great information and useful tools. So I really encourage you to, to download it and share it widely within your team and your practice. And then come together and identify which of the pieces that you'd like to use. I like the way it talks about the need to really focus on only what needs to be known and what an individual needs to do about it. To use plain language and just keep those key points to no more than 3 to 5. To be really, patients want just specific and concrete information, and it often patients and families comment on how helpful and useful it is when pictures are used or a demonstration is done. So not just talking about what you want them to understand, but really showing them either with pictures or demonstration. And to think about when you use different educational materials, to ask the patient, how useful or helpful it may be for them and the family. There's really a need to repeat and summarize that information. I know when I hear things more than once, it can make a big difference. And all of the things on this list can really serve as ideas. Take 2 of them, and plan and test 1 or 2 of the strategies with the next patient and family that you see, patient who has a diagnosis of asthma, and see what the impact is. The use of Teachback is what I'd like to focus on for the next few minutes. If I can have the next slide. This was a strategy that until a year or so ago I wasn't well versed in, but I was really excited when not only I learned about it, but I saw and heard and got to participate with practice teams who were testing the use of this. It is an evidence-based health literacy intervention, and it's a communication approach that helps with shared decision-making, and it is your opportunity to ask patients and the parents to teach back to you in their own words what they need to know or do, and it's done in a way that's not shaming. You're not asking them to do this because you think that they don't have a good understanding, or that they, you're not challenging their capability, but it's not a test for the patient or the family, but it's really about you saying to them, how well did I explain this to you? It's really a check for the understanding of how well you may have explained it, and the opportunity to reteach it so that by the time they leave, that there is full communication and understanding. I've received really thoughtful feedback from several pediatricians and nurse practitioners about how they tested this strategy. And, initially there's concern raised about, oh, this is going to take me so much time. But every one of them said that with practice, that concern was quickly removed. One of my favorites was a pediatrician who realized she didn't realize until she started using and practicing Teachback how much she talked. And that she talked way too much, and so that helped her. This schematic of the Teachback method shows you that, this is an idea to explain self-management process, then to assess the patient or the family's knowledge by asking them to teach it back to you, and then you can clarify if there are things that doesn't seem like they quite have it, and repeat the cycle until there's a shared understanding. The next slide talks about this method as a way to really ensure agreement and understanding about things like the asthma action plan, for example, that you're developing and along with the family. And it's essential to achieving that adherence to the plan. One way to do this is really by discussing the care strategy with the patient and family, and you can say, I want to make sure I explained it correctly. Can you tell me in your own words how you understand understand this plan when Lisa needs to use her rescue inhaler, for example? So you're not going to use questions that just need a no answer, or yes or no answer. So you don't just say, do you understand? And somebody can easily just say yes or no, and that may not be the case. Or do you have any questions, yes or no? You're really staying away from the use of yes-no questions. Rather, test just asking, tell me what you understand about this medicine. Or I want to make sure I explained it clearly. Can you tell me what you think, when you think, or how you think you need to take this medicine? So either of those questions can be the test of change that you do with the next patient and family who comes into your office with asthma. Next slide. So just to bring it together, especially if this is something that you haven't heard about before, it's about, using a caring tone and voice and attitude, plain language. It's your responsibility to ask the questions so in a way that the patient and family have the opportunity to give information back to you about, to make sure that they understand what is expected. And check in your EMR. If you don't have the ability right now to document the use and the response that you've gotten to using Teachback, it may be the opportunity, does a field need to be added, or you're going to decide that this is something you're going to record in a note so that you can then quantify how often and how well you're using this technique. On the next slide, this is your assignment for the coming month, or one of them, to please take some time, review the Teachback method tool, and plan and test using Teachback with the next patient who has a diagnosis of asthma and his or her parent or caregiver. If any of you have any experiences that you from already testing and using Teachback method with your patients with asthma or in other situations, if you can share that information either in the chat box or when we we're going to try to open the lines again at the end. Please share with us your successes and challenges that you've had using Teachback. So moving on, another area that we want to talk about today has to do with assessing patient activation, which, as you know, is the use of a patient activation measurement tool, a PAM, is one of your patient and family engagement measures for this project. I know that you probably have seen this before on other webinars about the various levels of patient activation, and really the idea of assessing where a patient or family is now, and then being able to move them along this continuum to increase their level of activation. On the next slide, this is a resource. I don't know whether it's one that you've seen previously. It's actually in the continuum that CMS put together for the purposes of tools and resources for those of you who have been doing this transformation work. But the one that's in there is really for the patient themselves. This is focused on measuring the parent and caregiver activation. Now, Insignia Health is a company. It's an LLC. So this is a proprietary tool and not one that it requires a license to be able to use it. It is copyrighted. But that said, if you Google the website for Insignia Health, you may be part of an organization that can, consider testing and using a tool like this as your patient and family, your activation measurement. So I'm showing it to you as an example. It's the type of tool that when a family or a family member would circle where they are with how confident they are or how much they feel that they know, you will easily be able to see whether or not where they are on the scale based on whether they disagree or disagree strongly that they're confident or knowledgeable, or whether they feel that they are confident and knowledgeable and can take responsibility for their child's care management. If this is something that you can consider. Now, this tool is one that you can see is simpler. It is available through the American Academy of Family Physicians. Their Family Practice Management publication is where it first appeared. 2 questions. One, where you can rate where the patient can rate, the family can rate where they are in confidence, health confidence, and where they are in terms of understanding health information. This may be what you adapt and test using, and think about, as you plan a test of change, think about how it can be delivered, who on the staff is going to deliver the use of this tool, and when. Would it be in the waiting room or when the MA or nurse rooms the family? Is it something that you want to send through the portal to be able to have it done prior to the visit and as part of the pre-visit information? It's up to you, but really important that you test doing it in different ways to see what's going to work best for your patients and families. Okay, so let's switch gears a little and talk about another aspect of the care management, which has to do with medication management and strategy. Seeing the results of the poll that you answered, at least I think it was about 2/3 of you said that you've been working on medication management, and we certainly will look forward to hearing some of your lessons learned and successes and challenges. And, you know, the idea of having a standardized, systematic method so that you can evaluate and support the patients and their caregivers in the medication self-management is just really what this message is all about. The idea of printing out a current list maybe and reviewing and reconciling asthma medications with the patient and family, and to document that this has been done, document that the review and reconciliation, that it's documented in the EMR, so that whoever is interacting with this family and knows that this is the standard of care, is really important. So again, you may want to encourage families to bring their medication and their devices with them to the visit, so that you can not only just have a list, but you can talk about, and they can ask questions if they have them, about the medications that they or their young child is using for their asthma care. So, you know, there are different ways that you can incorporate this strategy, but again, I encourage you to make sure that you put a system in place to be able to do this. Next slide. And certainly, you know, it's important for this to happen as part of the shared decision making for asthma action plans. We're going to talk more about the creation and maintenance of the asthma action plan during next month's webinar, and I look forward to hearing what the practice teams and the coaches can say about their experiences regarding that care planning, and the ways that shared decision making are being used and as part of this process. On the next slide, you know, one of the things with asthma support, it is more than just the medications that are prescribed themselves, but also the fact that there are devices to deliver these medications correctly. So important, again, as I said, you know, to be able to demonstrate, to teach families using Teachback to demonstrate the correct ways to use these devices, whether with the next patient you're talking about using how to use the spacer, or using a spacer with a mask, talking with parents about that, nebulizer use and connections, how to clean the devices and the inhalers, and for those patients who have EpiPens, to be able to make sure that they know the correct administration and when to administer the EpiPen. And remember, this is a team sport. So again, just reminding you that it doesn't have to be the physician who does all this teaching, that it's an opportunity for other members of the team to be doing this as well as part of the patient's visit. On the next slide, you know, remember, we're doing quality improvement here, not research, and that it really is important to consider. You know, you have a lot of good ideas that are being shared on this through this group and others that you're interacting with, and how you can use the Plan, Do, Study, Act cycle to do rapid cycles, just small tests of change with the next patient and family who come into your office who have asthma. It may be related to patient and parent activation measurement. It may be related to some of these other aspects like the use of Teachback. The next slide, as I said, you know, the other aspect of this is that it takes a whole team to do this work. It's not just the responsibility of the clinicians. And from the front desk to the back door, all of you can it's so important that you're involved, and including the parent and caregiver and patients as partners as part of this, the work that you're doing. So I think we have a polling question we wanted to ask you again before we open this up for some discussion. Jacinta, if we can put up. one more polling question. So while we're doing that, okay, here it comes. So would really like to know in the upcoming month, we asked you about what you did last month, but on the upcoming month, what pediatric asthma care QI activities can you commit to do? You can select all that apply, and if you can vote now, we'll see what you're thinking. Okay, great. All right, so we have responses of 50% from all, okay, across all all of these activities. The reviewing, continuing to review your QI activities, meeting with staff again and your QI team, continuing to develop your approach, meeting with patients. Half of you are going to do that as well, and developing the action plans for patients' pediatric asthma QI. So 50% in the next month. 50% of you said that you have no action planned at this time. Well, for those of you, I hope that we have that you have some thoughts and ideas based on what we've just been talking about. And I encourage you to go to the website on PCPCC specifically for this Pediatric Asthma Learning Network, and identify at least one tool or resource that you would like to test in the coming month. So thank you, Jacinta. And if we can go back to open discussion, I hope that in some way, either through the chat box or by unmuting everybody, that people can talk about. If we can go back, yeah, great, thank you. I wanted to hear, about some of the tools and resources we talked about last month, the asthma control test, the use of that, or asking a question or two about family strengths, or the use of pre-visit forms, things that would engage patients and families in conversation. Anybody have any experiences with those? Or any work moving forward in how you could plan or test an asthma support group? Maybe it's similar to one that Roshana spoke about, or I know one of the coaches shared with me that there's a practice team, a small practice that is now doing Saturday visits with 8 or about up to 10 appointments, hour-long appointments with families who have children with asthma, and it's being very well received by the patients and families, and especially by those who may not otherwise be able to get to a specialty appointment, but by having these once-a-month Saturday clinics for their patients with asthma, it's really making a difference. Anybody else have thoughts that they could share?
So Ruth, everyone should be unmuted now unless you've muted yourself. Just make sure you're not muted yourself. Or you could chat in any questions or comments. We're really interested in hearing what you're doing, and if you have any areas that are challenging that you want to run past Ruth or anyone else who's participating in the group.
Or anything that other needs that you have that we haven't touched on, or as of yet, and you need them sooner rather than later, or we'll make sure that in case it's something we haven't identified, that we get it for you. Talk about it.
I know that one of the things that came up in the follow-up survey that we did after the last call was return visits. Any ways that you found that engaging patients and families gets a higher rate of return visits?
Yeah, that has been brought up as an issue when everything's going well and their child's asthma is controlled and they feel comfortable and confident. There's not the realization that as part of the standard of care for asthma care management, that there are follow-up visits, that it's not just supposed to be an annual visit or just, only based on acute care. So one of the things that some teams have found has been helpful is just, often the families just aren't aware of how often they should be seen, and what the purpose is. And so once they have a better understanding, then it's something that they're more willing to schedule or do. So that may be a test of change, is the next patient to talk about the need for, especially if it's a family who may not be coming back to you. The other aspect is that sometimes it's a family who is seeing a specialist when, during the maybe the off months when they're not coming to you. And so making sure that you have that information and are co-managing that patient with the specialist. So yeah, in your mind, they're not following up, but they actually are being seen, but haven't been seen by you. And just getting that information will help you make sure you're in the loop, because you are the medical home for these patients and families. So 2 ideas. One is to share information routinely about follow-up, and the other is to find out or make sure that you have information if they're being co-managed.
Ruth, a question came in via the chat box from Diane Weiss, and it reads, these visits take an extended period of time when done well. How are practices getting paid adequately for the comprehensive care?
Good question. Any of the practices anybody have been able to code appropriately, in a way that you're able to get paid for the?
I think one possibility is that more value-based purchasing arrangements come from health plans, from Medicaid, and from commercial payers. Being able to show that you have better quality indicators, be it asthma medication management or reduced ED, will put you in a better situation for the value-based purchasing agreements. And I think it's also probably very strategic to be able to negotiate on the basis that you have a lower rate of ED usage compared to your peers or compared to statewide average, something like that. And that is one reason why it is helpful to be able to look at your metrics overall. But I think it is a challenge when there's a longer visit. I mean, another strategy we've heard throughout the Transforming Clinical Practice initiative is the need to think about creative ways to have that comprehensive visit. So it may not have to be the physician doing a lot of that, but a peer coordinator, or it could be a group visit. It could be one of the nursing staff doing with several patients. So that there may be different ways you can mix and match your clinical staff, your non-clinical staff, and patient combinations to do the visits more efficiently or effectively. But it's definitely a challenge. There's no question about that.
Yeah, good suggestions though. And I do continue to hear as you stated, the importance of documenting how much time is actually being spent, especially if you'll be able to do it in conjunction with improved measures to be able to negotiate as we move forward. Yeah, no, very good points.
Other thoughts from the group about what's worked or has proven to be challenging?
Or even something that surprised you? Have you asked for some informal feedback in the last month, and were families, anybody surprised that you were asking them? Or how your team is doing? Okay. Well, we do know that we're going to continue to talk about some of these aspects of asthma care management over the next 2 months, a total of 3 months, on different aspects. So if you please let Liza or me know, let me know. You can email me directly or through Liza. You know, we want to make sure that we're meeting your needs, and would appreciate hearing from you. If you have, those of you who are coaches, if you have some practice innovators that you would like to be able to highlight, we'll be happy to highlight them on a call, on our monthly call. It doesn't have to be formal presentations, you know, 5 or 10 minutes like was done today, to give you some information and sharing of what others are doing. That's we know how important that is to all of you as well.
So I did just want to say that through the Patient-Centered Primary Care Collaborative Support Network, which is part of our CMS-funded project, we are able to assist you with coaching calls. So if any of you are in the throes of a quality improvement initiative, or if you're practice coaches and you know that some of your pediatric practices are working through this and would like to have a one-on-one call with Ruth, we'd be happy to facilitate that. In the meantime, we hope that many of you will act on the action recommendation that was a couple of slides ago. We'll be following up probably in a week or two with a survey link asking you pretty much the same questions you answered earlier in the call about what actions you've taken and what actions you're intending to take. And we'll also ask you what assistance you need so that we can continue to refine these calls to address the specific needs you might be having as you're working through asthma care initiatives. So these slides will be available on our website, which is up on the screen now. We have a general website for the Patient-Centered Primary Care Collaborative Support Network, and we also have pages dedicated specifically to this asthma work. So if you go to the one that ends with learning, you'll find all of the resources that Ruth showed us today, except the copyrighted patient activation measure, as well as the slides that you've had today, and in the next couple of days, we'll have a recording of this call up. So Ruth, why don't I close it out from my end and then just turn it over to you to make any last remarks and close us up.
Okay, and I saw there was a question about the link to the information being posted, so you can see that's on the slide here that Liza just talked about. And again, I especially encourage you to take some time to look through the health literacy toolkit. I think that you'll find it's very helpful and has a lot of tools and resources that are easy to use, well thought out, and useful. Okay. We thank you so much for your time and your willingness to participate in this initiative. Please keep in touch, and we will look forward to talking to you again next month. And we'll be in touch in the meantime, too.